Hi, everybody. So I was driving home from today's lecture and I realized that the discussion board topic covers cranial nerves and we didn't finish that today. So I'm going to finish it up here in a couple of taped or recorded lecture videos for you that you'll have. You can watch them before you do the discussion board. And then at next week's after spring break at the following live lecture, we'll go right into the brain and the brainstem. So I'm going to complete today's lecture right now. So here we're on slide, roughly slide 27, I think. ALS, amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. It is a progressive degenerative disorder that involves bilateral degeneration of both the lower motor neurons and the upper motor neurons in the brain and the spinal cord. So it's one of those diseases that hits both upper and lower motor neurons. So I'm going to give you a brief synopsis here. I know someone's going to be covering that. I believe a group is covering that during our neurodisease presentations as well. So in ALS, the astrocytes, remember those cells, they fail to clean up the excessive glutamate, and that causes that excitotoxicity and additional nerve cell death. So some of the symptoms that we see with ALS are emotional lability, which is when a patient we see that in about 50% of these folks. There's uncontrollable laughter or crying that's not necessarily connected to the person's actual emotional state. So patients may start crying or laughing during an inappropriate time. Which can be, socially challenging for these folks. We also see a normal memory. Some of the other symptoms include, paresis because of the resulting atrophy. We see spasticity. We see clonus. We see the myoplasticity that we talked about today. You may see hyperreflexia or hyporeflexia because, again, these folks are having degeneration of both the lower and the upper motor neurons. So you may see a mix, or you're seeing a mix of the symptoms of both of those types of disorders. These folks often have a positive Babinski sign. They have atrophy. They have fasciculations, those quick twitches of muscle fibers of a single motor unit that are visible under the skin. They may also have fibrillations, which are brief contractions of a single muscle fiber that's not visible on the surface of the skin. So they, again, have a variety of symptoms of both upper and lower motor neuron damage. And there's a loss of lower motor neurons in the cranial nerve, and that can cause difficulty with breathing, swallowing, and speaking. And the general onset of this disorder is about age 50. We see more males than females suffering from ALS. It is progressive. The average lifespan after diagnosis of ALS is about 3 years. Usually folks die from ALS when we have destruction of the phrenic nerve, C3, 4, and 5. And of course, that's the diaphragm. So now we're going to begin the cranial nerve section. The cranial nerves are 12 pairs of peripheral nerves that emerge from the brain. They connect directly to the brain. So here's a picture of it on the right. They are numbered as they exit the longitudinal axis of the brain, starting at the cerebrum. Each cranial nerve attaches to the brain near its associated sensory or motor nuclei. And again, the nuclei are groups of cell bodies, right? So the cranial nerve is close to whichever nuclei it's connected to or associated with. The sensory nuclei relay information to the cerebrum, which is, the cerebral cortex, or the cerebellum. The motor nuclei receive convergent inputs from higher centers or other brainstem nuclei. Some cranial neurons are sensory, specifically. Some are specifically motor, and some carry both sensory and motor information. So again, these cranial nerves are highly specialized, differ from kind of your average spinal nerves in their specialization. Some cranial nerves, again, are motor, some are only sensory, and some are both. And some have unique functions. They can convey kind of special sensory information, like visual information or auditory information from our special senses, or vestibular information. Some carry information that's not shared by any other nerves. So if that nerve is knocked out, then there's no kind of double duty for other nearby nerves to carry that special information. So again, 4 basic functions for the cranial nerve. They supply the motor innervation to muscles of the face, the eyes, the tongue, the jaw, and 2 of the big neck muscles, the sternocleidomastoid and the trapezius. They also transmit some amount of sensory information from the skin and muscles of the face and the TMJ. They also transmit special sensory information related to, of course, all the special senses: vision, visual, auditory, gustatory, olfactory, and visceral sensations. And they provide parasympathetic regulation of pupil size, curvature of the lens in the eye, heart rate, blood pressure, breathing, and digestion. So when you take a look at those functions, that's a huge number of very specific information that these nerves transmit, particularly of the face and the eyes and the mouth. So you can if you take a look at just that list, right? You're looking at, chewing. You're looking at tasting. You're looking at smiling. You're looking at how the eyes move, and even things like heart rate and blood pressure, breathing and digestion. So those are some huge functions that these cranial nerves impact. So if we knock out some of these cranial nerves from a head injury or from a stroke, that can be, pretty catastrophic. And keep in mind that the cranial nerves are really clinically important because, of course, they carry all of that information that we just talked about, but they also provide clues to an underlying central nervous system problem. So clinicians will often assess, especially like neurologists, will assess cranial nerve function using several standardized tests. So here's cranial nerve number 1, the olfactory nerve. This is a sensory nerve. It carries sensory fibers for the sense of smell. You can see here the olfactory nerve fibers in yellow. They pass from the roof of the nasal cavity through the cribriform plate of that ethmoid bone, and they form the olfactory nerves. They synapse in that kind of bigger yellow bulb, and that's the olfactory bulb, and then they proceed directly into the cerebrum via the olfactory tracts. And they are this information, that sense of smell, is interpreted in the temporal lobe. So they're very specialized. They're carrying, smell, which of course also impacts taste. And so olfaction, the sense of smell, is the only sensory input that can reach the cortex without first synapsing in the thalamus. So it has kind of a direct line into the cerebrum. It does not have to go through the thalamus, which we'll learn later is kind of the way station or the clearinghouse for sensory information. Olfactory nerve cells are replaced every 30 to 90 days if they're working properly. They tend to decline with age, which is why as we age, our sense of smell declines. It'll be interesting now post-COVID with folks who lost the sense of smell, what kind of, temporary or permanent damage some of these folks might have with sense of smell and taste. So I'm going to pause it here, and then we're going to start the next little taped lecture in a second.